Good evening, everybody, and welcome to today's session. Today is January 24th. Some of you are going for the upcoming June Foreign Medical Graduate Exam and the AIMS and PGI in May 2020, and a large number of you are going for the NEET PG 2021. So, I use a lot of PowerPoint slides to teach. But what I found is, on any given day, if there need to be a good connection between the teacher and the student, seamlessly connected, nothing can beat the chalk and talk, right? So, the handwritten notes has a kind of a cerebral spatial orientation and a connectivity between the teacher and the student. So that is the reason I thought to make a good amount of handwritten notes for all of you, even those who are preparing for their final year MBBS exams, or whether it is the FMGE, AIMS, May, or PGI or NEET PG. This is going to be a common notes and a quick summary that you need to master first things first when you are going for the exam, and a very fast way that you can do the revision. Good to see Indrajit Kumar, Dipendra Mehta, and many more who are all online. Yesterday I was in the chilling winter of Dehradun with wonderful students of the government Doon Medical College. Very interactive, active. Unknowingly, for about 4 hours we have spent without knowing how the time passed in a live class. So I'm very happy. So today I returned. Yesterday I could not take the class. Good to see Gibson and many more who are all online. Please inform your classmates that the live class has started in the your WhatsApp study groups, etc., etc. So, doctor, yes, let us start today. Our focus is on gynecology and obstetrics. So, labia majora, what do you want to remember about it? It is homologous to the scrotum in the male. And good to see Akshay Mishra all the way from Russia. A toast of vodka to Akshay. Good. Now, labia majora is homologous to the scrotum. And it also need to be remembered because round ligament is the structure which will be terminating along the anterior end of the labia majora. So that is the reason you need to remember. So what does labia majora, mons veneris, what do they contain? You should know that they contain hair follicles, sebaceous glands, modified sweat glands, which are also called as apocrine glands, right? You know, hidradenitis suppurativa. So you should remember the apocrine glands, which are the modified sweat glands. So they are the ones which are the part of the labia majora is what you need to remember. Now, labia minora, it is homologous to which structure in the case of the males, doctor? Penis. The ventral part of the penis is equal to the labia minora in case of the females is what you need to remember. Clitoris, that is the homologous structure to the male pelvis, finally. Now the vestibule of the vagina, typically it has got 4 openings. So there is a urethral opening, vaginal orifice, and on the both sides Bartholin ducts will be opening into it. And there are a lot of paraurethral glands which are called as Skene's glands. Skene's glands also will be opening into the vestibule along the posterior aspect of the vestibule. That is what you have to emphatically remember. Now doc, fossa navicularis. What is the meaning of fossa navicularis? Typically the posterior part of the vestibule between the fourchette and the vaginal opening, it is called fossa navicularis. Now one of the favorite question in the exam is hymen, imperforate hymen. There are so many things about hymen. At least 4 points you need to know about hymen. So what are the things you are going to remember? What is the histological lining of the hymen? Squamous epithelium, both to the exterior and the interior, both of them. Is there no sound coming? Both to the exterior and as per the sound is coming, right? Probably you have put off the on the YouTube there is a place where you have to put on the sound. Maybe your speakers are off. Please check that. Yeah, good. So doctor, hymen is lined by the squamous epithelium on both the sides. Hymen is torn. Obviously, with the sexual activity, hymen is torn. Most commonly, where is it torn? Posterolaterally or posteriorly. That is the classical location where the hymen is torn. And what is left over after the childbirth? The hymen will be left like tags. And those tags are called carunculae myrtiformis is what you have to remember. Now, let us talk about vagina. So, doctor, a lot of times what happens is when we are solving MCQs, multiple choice questions, each of this is a single liner in the tomorrow's exam. And you are supposed to have that anatomical orientation. In fact, so that is the reason there is a compendium of concepts. First, you need to be mastering that. In that list of in those concepts, some are facts. You can't help it. They are merciless facts. There are some things that have reasoning, right? And there are some lists to remember. 1, 2, 3, 4. What are the 4 openings into the vestibule of the vagina? You should know what are the 4 openings. There is a list of things. List go list. Facts go facts. Logic go logically. You need to master. So totally, doctor, there is about 600 pages of the handwritten notes in gynecology. Actually, if I happen to print it, it would have been 300 pages. Handwritten means it is little spatially aligned. You have a lot of white space so that you can write your own notes also, right? So 600 pages of handwritten notes we are creating in each subject. Gynecology 600 pages, obstetrics 600 pages. Handwritten notes thoda mota hota hai. But you please bear with me. And you give me a feedback. Handwritten notes is like on the teacher writing on the board. You will remember much better with much better emphasis. And you can add some more points to that handwritten notes. And that makes you strong in the concepts. So our goal is 19 subjects. Each subject there is about 600 pages handwritten notes and about 4,000 to 5,000 important points. Once you master them, doctor, any entrance exam. Damn, it can be final MBBS exam, it can be first MBBS exam, whether it is FMGE, USMLE, or whether you say you are going to AIMS, All India, PGI, CHIPMA, any exam in the world, or you are going to Philippines, licensing exam, anything. This is the fundamental concepts that you need to be very sure about. Okay, doc? Now, anterior wall of the vagina is 7.5 centimeters. 15 centimeter scale is there, half of that. Posterior wall is more deeper, and it is 9 centimeters. So, typically, if this is anterior, this is posterior. If you are having vagina, the anterior wall of the vagina compared to posterior wall of vagina, posterior wall is more deeper compared to that of the anterior wall, is what you have to basically remember. The upper vagina, fundamentally cervix become vagina. So the upper part of the vagina is separated from the cervix, and when it is getting separated, it will form fornices. Anteriorly one fornix, posteriorly one fornix, laterally fornices. So that is how virtually cervix is like a fruit tucked into the laddu, like that. Just like imagine you have a kismis dry fruit, you are tucking into the laddu, like that. The cervix is tucked into the vagina, and typically that lead to all these fornices, is what you need to remember. Now comes the favorite question of the examiner. Deepest fornix of all. Obviously, posterior wall is longer compared to anterior wall of the vagina, right? So posterior fornix is the deepest. Shallowest fornix is anterior fornix. And if you happen to take a cut section of the vagina, what is the shape of it? It is H-shaped is what you need to remember. Now, doctor, let us talk about the relations of the vagina. You know very well that the uterus typically forms the cervix and finally vagina. And you are having the bladder, right? So the bladder is also draining out into urethra. So that is the reason, if you take the vagina, in the lower 2/3 of the vagina, anterior relation obviously will be the urethra, which is bringing the urine from the bladder. Upper 1/3 of the vagina is related to the bladder. Bladder is anterior, urethra anterior, uterus behind it, and vagina behind it. So, lower 2/3 of the vagina is related to, anterior to the lower 2/3 of the vagina is urethra. Upper 1/3 of the vagina, anteriorly you are having the bladder. That is what you need to remember. Now, what are the posterior relationships of the vagina is a very important question. 007 K007. Where can I find these YouTube videos on online MBBS, sir? So these YouTube videos we will be uploading as we finish the discussion. We will be uploading it into the onlinembbs.com. You have a lot of videos with a lot of PowerPoint slides. So of late I am feeling that handwritten notes is a more connecting way to the students. That's the reason I am trying to create the content. It's like a teacher already ready with all the illustrations that he wanted to teach, and the students are very well aligned. So we will be publishing this handwritten notes into the form of an e-book and make it available. And if you are really wanting a printed copy of it, we will also print it and then make it spiral bounded, xerox it, and then provide it to you, post it to you. That's what we are going to do. But just it's a beginning. I mean, we are still a long way. This time revision we wanted to do with handwritten notes, right, Doc? Now, pouch of Douglas, ampulla of rectum, perineal body. Obviously, bladder is first, uterus is next, behind that is your rectum, right, Doc? So, pouch of Douglas is in the upper 1/3, posteriorly. Akshay Mishra is saying, thank you, sir, for this notes idea. Please make this happen. Sure, doctor. All you guys make me a student every day. I try to find more innovative, more creative, more newer methods how we all can study together more effectively. That is whole of my goal. Without knowing last 20 years how passed like that. Every year students suggest. Last year Madhushri Manya, who is our student, said, sir, before you start the MCQ based session, topic wise MCQ based session, run those MCQs like a quiz. Let us all play that quiz and then you start the class. That was a super hit idea. Everybody liked. Then somebody suggested we will do Kahoot kind of quizzes. That is another super hit idea. But now the 2020 ka super hit idea would be, we prepare handwritten notes and try to summarize about 30,000 points from all the 19 subjects so that last moment revision become easier for all of us. That is the plan. Deal? Good. Now, doctor, pouch of Douglas is posterior 1/3. Ampulla of rectum is middle 1/3 of the vagina's posterior relationship. Perineal body is lower 1/3 of the vagina's posterior relationship. That is what you need to remember. Now, doctor, if you look at the various lateral relationships of vagina, so you imagine the vagina and a lot of things are attaching laterally to it. So what are the various structures attached laterally is a very important question. Dipendra is saying handwritten notes is more easier to learn and make our learning more efficient instead of reading bulks of books. Excellent, Dipendra. Thanks for the feedback. So yesterday it was a excitement. 300 students, all faculty in the Doon Medical College, in the lecture gallery. We were playing with ECGs. Even a first year student is able to tell, sir, this is the left bundle branch block. Sir, this is the Mobitz type 2 block. Sir, this is the place where you are finding left axis deviation. Sir, this is the left anterofascicular block. I'm so happy with the communion of live face-to-face students. It was a great excitement. Next week I'm going to Guwahati to deliver a lecture in the Guwahati Medical College on clinical neurology, made easy in 3 hours. So if you are from Guwahati, let me know. I will update you about the venue and address where we are going to have an interactive session. So I love meeting students face to face because that makes me to understand, to become a student, to know their difficulties, to learn what actually they want. How can we make it easier for them to learn, to remember, to reproduce in the tomorrow's exam efficiently. I'm so happy. Lot of our students called and said, sir, हमको FMGE में exam clear हो गया. हम बहुत we are very happy about the way we got tuned in the last 3-4 months. So the role of a teacher is ultimately to tune you, doctor. But you are the one who has to carry the pregnancy. Please remember. Any teacher's intention will be to help the student to learn, to inspire him to learn, to inspire him to open the books and read. Any teacher's objective will be ultimately that only. So that is the reason any teacher with whom you are convenient, who is nearby to you, you can. But remember, Dr. Murali Bharadwaj will be there with you every day, every time, anytime, until you get the top rank in the tomorrow's exam. Right, Doc? Now, Agastya is saying, sir, please conduct the class in Hyderabad. Yes, very much. From this upcoming Sunday, we are having live session in Hyderabad every Sunday, 45 Sundays. Please take opportunity to join the face-to-face classes, and also that become live broadcasted, so that even if you're not in Hyderabad, you get an opportunity to participate. And every Sunday we will finish one subject, one Sunday. That's how we will do the revision. We will do 2 rounds of revision over a period of 45 weeks. From Jan 26 to June 30, one round of 19 subjects. From there up to November 30, another round of 19 subjects. So that even if you miss in one round, you are still part of the another round. So, doctor, what are the lateral structures to the vagina? McEnroe's ligament and the pelvic cellular tissue, levator ani muscle, bulbocavernosus, vestibular gland, Bartholin's gland. They are the structures above downward. सबसे ऊपर क्या रहता? McEnroe. After that, levator ani muscle. Imagine the vagina and things attaching to it laterally. Bulbocavernosus, vestibular gland, and Bartholin's gland. Now, doctor, वाह, अक्षय मिश्रा साहब बहुत दिलदार बात बोल रहे हैं. अर्जुन तभी अर्जुन बना क्योंकि उनके साथ द्रोणाचार्य ऐसे गुरु थे. So we all want to become your Arjun in medical field. I'm honored, doctor. Definitely. Cervix and its fornices. What are the various relationships? Very important structures which are surrounding the cervix of the uterus. Imagine yourself to becoming a gynecologist and doing hysterectomy. Uterine vessels are surrounding the cervix. McEnroe's ligament surrounding the cervix. Ureter, typically it will be passing adjacent to the cervix. That's the reason during hysterectomy there is a great chance that you are thinking that you are clamping uterine artery, you may end up in injuring the ureter. That is what you need to remember. Now, doctor, let us talk about vaginal secretions and the pH. In the vagina, there is a resident medical officer. Just like resident medical officer, you have an inhabitant bacteria called Dodeline's bacteria. They are lactobacilli. They convert the glycogen, which is there in the vaginal epithelium, into lactic acid. So glycogen to lactic acid conversion, it is the estrogen. Estrogen produced will make the vaginal epithelium glycogen to convert into lactic acid. So when will you have more estrogen? After puberty. So that is the reason after puberty the vaginal secretions are more acidic in pH. Because estrogen will make more glycogen become the lactic acid is what you need to remember. Now, doctor, this is an important list that you need to remember. pH of vagina. Typically it is acidic in reproductive age group and it will be varying with the age. In the newborn, I told you, no, however brilliant you are, there is no other option than to mug by heart certain facts to pass MBBS exams and to pass entrance exams. Newborn 4 to 5, 6 weeks old 6 to 8. Puberty, it changes from alkaline to become acidic. In the reproductive age group, typically it is acidic. It is acidic. In the pregnancy, 3.5 to 4.5 because there is more estrogen during pregnancy. During menses, it is 6 to 8. During menopause, once more 6 to 8. So this is what you have to fundamentally remember about the pH of vagina. So if you look at the pH of vagina, it is highest in the upper part. Why? Because vagina ke upar kya hai? Above vagina, what do you have? Cervix. The cervix has alkaline secretions. They mix with the admixture of the cervical mucosa is there, and that lead to the alkaline pH in the upper part. Then very important thing you need to remember is one of the favorite MCQ. Does vagina have any mucus secreting glands? No, sir. Vagina does not have any mucus secreting glands. Vagina, it's like Himalayas melt and water become Ganges. So who is Himalaya? It is the cervix, which is above the vagina. So vagina does not have mucus secreting glands, and vaginal discharge is basically the one which is flowing from above, not produced inside the vagina. So what are the components of these vaginal secretions? Endocervical glands. Inside the cervix, there is one ectocervix, endocervix. That part of the cervix which is within the vagina is ectocervix. Above that is endocervix. So endocervical glands, endometrial glands, and Bartholin's glands. They are the ones which are oozing into the vagina, responsible for the vaginal lubrication and secretion is what you need to remember. Vagina not only is having Doddelin's bacillus, it also has pathogenic organisms also. Clostridium welchii is also there. So you should not forget, posterior wall of the vagina is longer than anterior wall. So what is common thing about esophagus and vagina, doc? Is there anything common thing? Both of them don't have a serosa. Esophagus also doesn't have a serosa. That's the reason esophageal tumors will spread into the mediastinum like anything. Similarly, the vagina also has no serosal covering except a small area in the posterior aspect of the vagina which is covered by cul-de-sac. That is the only thing which is covered, but otherwise overall vagina does not have serosal covering is what you need to remember. Now doctor, what is the blood supply of the vagina? Lymphatics, nerve supply of vagina. If you are MBBS final year exam going, this is going to be short notes. And if you are preparing for entrance, this is a hot MCQ. Lymphatics of vagina. Divide the vagina into upper flora, middle flora, lower flora, upper 1/3, middle 1/3, and lower 1/3. Upper vagina lymphatic drainage is same as cervix. Cervix become vagina, right? So upper 1/3 of the vagina lymphatics are same as cervix. Middle vagina by the internal iliac group of lymph nodes, and lower 1/3 of the vagina is by the superficial inguinal group of lymph nodes is what you need to remember. Now doctor, blood supply of vagina. Very important. Vagina gets the blood supply from the artery, descending vaginal artery. It is a no-brainer to remember about it. Vaginal artery only will supply, what else will supply? But the question of the examiner, descending vaginal artery is a branch of which vessel? It can be branch of uterine artery, or the descending vaginal artery can derive from internal iliac artery. There are two ways by which the descending vaginal artery can originate. Similarly, internal pudendal artery. It is the one which is supplying a lot of pelvic organs. That is also supplying the vagina. Middle rectal artery. That is also supplying the vagina. So you should remember. Now what is the nerve supply of vagina? It has both sympathetic, parasympathetic, and obviously parasympathetic is craniosacral outflow. That's the reason S2 to S4 is the parasympathetic innervation of the vagina is what you need to remember. If you look at the vagina, there are only free nerve endings in the mucosa. There is no plexus, only free nerve endings are seen in the vaginal mucosa. That's what you need to remember. Now, doc, the vaginal epithelium and the cytology of the vagina is a favorite area for the examiner. So you should remember, it is the stratified squamous epithelium which lines the vagina. Stratified. Stratified is you are having multiple layers. Stratified squamous epithelium is the lining of vagina. Whereas in the newborn vagina, female vagina, newborn baby's vagina, it is the transitional epithelium which is the lining epithelium. Now if you look at the vaginal cytology, doctor, there are parabasal cells, basal cells, intermediate cells, superficial cells. That's how you calculate the maturation index. What type of cells are predominant? Parabasal and basal cells, when there is no hormonal influence, like menopause, that time you find parabasal basal cells. After ovulation, when there is a lot of progesterone produced by the corpus luteum, that is the place where you have intermediate cells. And before ovulation, during the follicular phase, when the estrogen is very high, that is the time where you have superficial cells. That is what you need to remember. So, intermediate and superficial cells. Is there anything common between them? Superficial is estrogen, intermediate is progesterone dependent. But both of them under the influence of estrogen, they contain glycogen. That is common to both of them. Glycogen is abundant in both intermediate and superficial cells. Now comes the favorite hot area of examiner. So doctor, what you should do is, before exam, one of the greatest challenges that will remain before exam is, in one day can you do the revision? In one day can you do the revision? I still remember way back in 1990 when I wrote my 12th class exam. I used to have a friend called called as Jagdish. I used to have all friends who are more physics oriented guys, maths guys, MPC guys. So he got out of 150 marks in mathematics, 149. But he once more took an exam. It's called improvement exam. Just that in improvement exam he wanted to achieve 150 out of 150. Utna perfectionist hai wo. And this guy Jagdish, 2 days before exam, he used to sit with the IIT joint entrance maths book, 12th ka. There used to be 2000 problems. He used to put alarm and solve all 2000 problems in 2 days. Tuck, he used to solve. And he used to always say, What is an important indicator that you have thoroughly prepared? The simplest indication is, if I give you 12 hours time, can you be able to do the revision end to end of all important things in a given subject? If you are able to consolidate, doctor, it is a proof that you have studied very well. Okay? Even, what is the difference between a good teacher and bad teacher? A bad teacher takes 1 week to do revision or 2 weeks to do revision. A good teacher can be able to revise within about 7 to 8 hours what is all that is required that should be pushed to a student. So, how is that possible? If you are very sure, what are the things like a mantra examiner expects from you, you should have in tips, no surprises in the exam hall. So that is what we are trying to achieve, doctor. So how does the development of the various genital organs happen? Clitoris develops from genital tubercle, labia minora from genital folds, labia majora from genital swellings. They are also called labioscrotal swellings. And vestibule of the vagina, vestibule develops from the urogenital sinus. That is what you need to remember. Now, doctor, let us talk about the neurovascular supply. How is the blood supply of the vulva? Typically, vulva, the blood supply comes from the pudendal artery. Pudendal nerve offers the sensory innervation. And what is the lymphatic drainage? Lymphatic drainage of the vulva. First, from the vulva, the lymphatic drainage goes to superficial inguinal lymph nodes. And then it will be going to deep inguinal lymph nodes. That is the story of vulva. Why you need to know? Because there is a vulval carcinoma. That is the reason you should know. Now, in the labia majora and in the mons venerum, you are having apocrine glands. From these apocrine glands comes the hydradenoma vulva, is what you need to remember. So one of the favorite questions of the examiner is, from where does the hydradenoma of vulva originate? It is from the apocrine glands, is what you should answer. Now, doctor, if you look at the female genital tract, this is one list that should directly sit in your mind and you should be able to answer. Very good to see 26 online students, Lohita, Akshay, Dipendra, and many more. Very good. You're all going to promise me that you're going to subscribe into onlinembbs.com so that on every Sunday, 45 Sundays, morning 9 a.m. to 5 p.m. we have a live face-to-face class in Hyderabad, which is live broadcasting. So that you participate and take opportunity to quickly do the revision of every subject within one day. That is going to be the beauty part of how to consolidate the preparation and go for the exam. Okay, doc? Now, uterus, columnar epithelium. Newborn vagina, favorite question. Transitional epithelium. Adult vagina, stratified squamous epithelium. And very good, Rajat. The promise is to make you proud in NEET 2020. I am waiting for my Super 30 batch to come out. Very good. Fallopian tube, columnar ciliated epithelium. Please remember. Because fallopian tube sperm has to do rocking, right? Then endocervix cervical canal, high columnar. Bartholin's gland, low columnar in a single layer. Bartholin's duct, it is a multi-layer columnar. And ectocervix, It is squamous epithelium is what you need to remember. Now, one of the favorite questions of the examiner, doc, the various arteries that you need to know in gynecology. Already we studied it in anatomy, but still. Internal iliac artery, one of the important arteries. Internal iliac artery, uterine artery, ovarian artery. You have to be 100% sure if you are reading gynecology and obstetrics. It has one anterior division, posterior division. Only anterior division supplies the pelvic organs. That's what you should remember. Now, doc, if you look at the internal iliac artery, what are the branches of the anterior division? What are the branches of the posterior division? Anterior division में होता है visceral, parietal. Posterior division does not give any visceral, and the parietal branches are there. So you should remember visceral from the anterior division of the internal iliac. What are the branches? Obviously, uterine artery not only internal iliac artery is important for bladder. So one superior vesicle, inferior vesicle. Internal iliac is important for uterus, so uterine artery. It is also important for the rectum, middle rectal artery, and the obliterated umbilical artery. They're all the divisions of the branches of the anterior division of the internal iliac artery. Then what are the parietal branches? Internal iliac's anterior division gives rise to vaginal, obturator, inferior gluteal, internal pudendal. They are the various parietal branches. Posterior division does not give any supply to the viscera, but it will give to the various parietes. So you should remember slip. P is posterior division. Right? So earlier also we discussed I means S means superior gluteal. Then you are having the other three branches of the posterior division. So slip. So this important division of anterior posterior division you have to be very sure about. Now, doctor, ovarian artery. What are the various branches supplied by the ovarian artery? It supplies ovary. The name itself says, hence it supplies ovary. Not only ovary, ovarian artery also supplies ureter, fallopian tube, round ligament, and also it gives anastomosis to the uterus. Uterine artery and ovarian artery, they form a mafia, nexus. So uterine anastomosis, round ligament, fallopian tube, ureter, and also ovary. That is the ovarian artery branches. From where does the ovarian artery arise? It arises obviously from aorta, but below the origin of the renal artery. It is infrarenal in its origin from the aorta. Then one word about ovarian vein. On the right side, what do you have, doctor? Liver. Liver means you will remember hepatic vein. Hepatic vein means IVC, right? So you remember the thing. Liver is on right side. Ovarian vein on the right side will go to IVC. And on the left side, it will drain into the left renal vein. And the left renal vein later drains into IVC. But ovarian vein on right side, even testicular vein also. On the right side, directly drains into IVC. On the left side, it will be draining into the left renal vein. That is what you should remember. Now, what is the surgical anatomy that you have to know about internal iliac artery? Internal iliac artery is the one which you will be ligating. If there is a very severe postpartum hemorrhage, you are unable to control postpartum hemorrhage. That's right. Dipendra is saying left will take a very long route. Absolutely. So to control severe postpartum hemorrhage, you have to ligate the internal iliac artery. Where do you ligate that? Typically, common iliac artery will undergo bifurcation. So, the common iliac artery's bifurcation, after the bifurcation happened, 2.5 to 3 centimeter distal to the point of bifurcation. If this is the bifurcation into internal iliac and external iliac after the bifurcation, 2.5 centimeters after the bifurcation, you have to ligate. By doing that, you are preserving the posterior division. Posterior division of the internal iliac is the one which is supplying the lower limb. Parietal branches are there that you don't want to disturb them. So that is the reason you have to ligate the internal iliac artery 2.5 to 3 centimeters distal to the point of bifurcation of the common iliac into external iliac and internal iliac is what you need to remember. Then how do you do the dissection? It has to be done lateral to medial, so that you will be avoiding damage to the hypogastric vein. So that is a little bit about the story on few important things in gynecology. Yeah, still the story is on. The next vessel that you need to remember is uterine artery. What is uterine artery? It is the terminal branch of the internal iliac artery's anterior division is the uterine artery, is what you should remember. So what is the surgical anatomy of uterine artery, doctor? Uterine artery crosses the ureter. If this is the ureter, uterine artery is crossing the ureter. And this happens typically near the cervix. If this is the cervix, 2 to 3 2 centimeters lateral to the cervix, the uterine artery will be crossing the ureter. That's the reason if you try to clamp the uterine artery, you may end up in injuring the ureter. Right? Now, what are the common sites where ureter can undergo injury? This site, where uterine artery is crossing the ureter, iatrogenically, it can get injured, most common reason. Second is at the pelvic brim, when the ureter is crossing, the pelvic brim is the second most common site. Now, this uterine artery is supplying the uterus. Very good. So, what are the various layers? The name will keep changing. Outer 1/3 of the myometrium of the uterus. Outer 1/3, typically it is called arcuate artery. Inner 2/3 of the myometrium, it's called radial artery. Then inside what do you have? Basal endometrium. That's called basal artery. Superficial endometrium is called spiral artery. That is what you should understand. Now let us talk about fallopian tube, doctor. Fallopian tube is lined by ciliated columnar epithelium. Because the sperm has to be rocked. What is the blood supply of this fallopian tube? So you know very well that from the uterus the fallopian tube is arising. Ultimately it has got a fimbrial end, ampulla and all that blah blah. Lateral 1/3 is by the ovarian artery because it is close to the ovary. Understood? Medial 2/3 because it is originating from the uterus. So medial 2/3 of the fallopian tube is by the uterine artery is what you should remember. What is the lymphatic drainage of the fallopian tube? The lateral part goes to ovarian lymphatics. From there it will go to lateral aortic group of lymph nodes. Whereas medial part will go to the cornu of the uterus. right? The cornu of the uterus, lymphatics will be going to superficial inguinal lymph nodes. So that is the difference in the fallopian tube's lymphatic drainage. What is the length of the fallopian tube? Favorite question. 10 to 12 centimeters is the length of the fallopian tube. Now, if you look at the fallopian tube, it has a fimbria. It is also called infundibulum. Ampulla, which is the widest, largest part. Isthmus and interstitial part, which is burrowing into the uterus. So, one of the favorite question is, few tailoring measurements of each of them. Fimbria, diameter is 6 millimeters, length is 1.25 centimeters. Ampulla, it is the place where fertilization occurs and it is widest and longest. Isthmus, it is 2.5 centimeters long, diameter is 2 millimeters, and it acts like a physiological sphincter. Isthmus part. Finally, that part which has gone burrowed into the uterus, interstitial part, it is 1.25 centimeters long, diameter is 1 mm, it is the narrowest part. Now comes the favorite question. Interstitial part of the fallopian tube has no longitudinal muscle, it has only circular muscle. That is the reason it acts like an anatomical sphincter. Interstitial part is anatomical sphincter is what you should remember. Now, one word about the pec cells. I just draw a picture of whiskey peg for you to remember. Small peg, large peg. So, pec cell is unique to the fallopian tube. No one knows what is the function of pec cell. Right? Now, there are secretory cells in fallopian tube and they produce the pyruvate. Where does the fertilization occur? In the fallopian tube. So after sperm, ovum married each other, fertilization happened. They require food. No, young couple require food. So that food is pyruvate, which is produced by the secretory cells of the fallopian tube is what you need to remember. Now comes the main part of our story, uterus. Everything, anything about uterus you should know. If you want to become MD Gynecology Obstetrics, you should know everything, anything. The length, the weight, the volume, also called capacity. Non-preg nulliparous women, non-preg multiparous women, pregnant women. You should know the measurements, tailor. You are the ladies' tailor, so you should know the measurement of all the scenarios. This is the favorite area, doctor. Definitely one MCQ comes from this area, you have to be 100% sure, right? So, non-pregnant nulliparous women, the length of uterus is 6 to 8 centimeters. Physically imagine a scale, half scale. Long scale, short scale. Short scale is 15 centimeters, long scale 30 centimeters. Short scale, in that half of it is non-pregnant nulliparous uterus length. Non-pregnant multiparous uterus little more stretched, 9 to 10 centimeters. Pregnant, the fetus is 35 centimeters, so it will be 35 centimeters stretched. Then what is the weight? Non-pregnant nulliparous 50 to 70 grams. Non-pregnant multiparous 80 grams. Pregnant 1000 grams. 1 kilo uterus is what you need to remember. Then what is the volume? Volume is only 10 ml if it is non-pregnant, but it becomes 5 liters. Capacity, oh, very big room. Huh? The fetus will be thinking, wow, mom's womb is very good. Huh? 5 liters, independent east-facing villa. That's what the baby will feel, 5 liters. Now, doctor, there is a body, there is a cervix, there is an area called isthmus. So uterus, what is the shape of it? It is pyriform in shape. It is antiverted, anti-flexed typically. And what is meant by angle of antiversion? What is the angle of anti-flexion? Very simple, doctor. Uterus is becoming cervix. Cervix is becoming vagina. Vagina is inclined by 45 degrees to the horizontal. So, if you look at the angle between cervix and vagina, you call it as version. Between the cervix and uterus, you call it as flexion. Agreed? So, flexion, it is like your नवाब महाबली अकबर जा रहे हैं और आपके सामने खड़े हुआ आपका मंत्री ने वो कैसा he has put his head down, he has put his hip also, he flexed, salam sarkar bola. So imagine head is the uterus, trunk is the cervix, lower limbs are vagina, right? So between vagina and cervix is antiversion, between cervix and uterus is antiflexion. So antiversion is 90 degrees, antiflexion is 120 to 130 degrees is what you need to remember. Whenever we say antiflexion, we are talking at the level of internal os. Because it is between cervix and uterus, we are talking antiflexion at the level of internal os is what you need to remember. So doctor, between the vagina and the horizontal, you have 45 degrees angle. Now let us talk about the body wall of the uterus. There is a perimetrium surrounding the uterus, myometrium the muscle, endometrium the mucosa. The perimetrium is the serous coat. Myometrium, it has a outer longitudinal, inner circular. And between the two, you have interlacing fibers, which are both circular and longitudinal. And they are called the living ligature of the uterus. So, uterus contracts and makes the blood vessels to stop bleeding because of this middle interlacing fibers, which are called the living ligatures, is what you should remember. Now, let us talk about endometrium. Endometrium is a mucus layer, but it does not have submucosa, no submucosa. That means myometrium directly attaches with the mucus. There is no submucosa layer between the two. Then, if you look at the epithelium, surface epithelium of endometrium, it is a single layer of ciliated columnar epithelium until puberty. But after the puberty, there are no cilia. For the endometrial epithelium, it is not ciliated after puberty. And the endometrium is directly attached to the muscle coat. There is no submucosal layer. And there is a lamina propria, surface epithelium, but no submucosal layer. That's what you should remember. Now, doctor, let us stretch our imagination. This is the uterus. Fallopian tubes are inserting into it. If you take this plane where these fallopian tubes are originating, above that it's called fundus, above the opening of fallopian tubes. The place where fallopian tubes open, it is called cornu. Favorite question is, there are three structures which attach to the cornu. Round ligament, fallopian tube, ovarian ligament. Same place, three structures come and insert. You need to remember them in this order. Above all, highest is round ligament, then fallopian tube, the point where they are attaching. Switchboard. What are the three things? Round ligament on the high, then fallopian tube, then the ovarian ligament. These are the three structures that attach to the cornu, is what you should remember. Then one more thing. Suppose if you take, these are the structures not above to below. It is from anterior to posterior. Sorry. Most anterior is, so typically, if this is anterior, this is posterior. More anterior is round, then fallopian. More posterior is ovarian ligament. This is the order in which they are attaching to the cornu from the sides. Okay. Then from above to below, of all the three structures, fallopian tube is above, round ligament and ovarian ligament are at the same level below the fallopian tube. That is what you should remember. Now, doctor, this is one important mathematical figure. You are like a construction engineer. You should know clearly understand. A lot of people will have confusion about what is what. With that confusion only, people finish their gynecology, obstetrics and final year MBBS exams also. See, doctor, one more common confusion is in orthopedics. People have a confusion, where is intracapsular fracture, what is intertrochanteric fracture, what is extracapsular fracture. They always have a confusion. Now, doctor, these are the places where the fallopian tubes are inserting cornu. Above that, typically you are having the fundus. This is all called body, right? Then here you have an area where it is all merging. That pyriform shaped uterus is merging. This is called anatomical internal os. Below that you are having a histological internal os. After that you are having cervix. In the cervix you have a supravaginal portion that's called endocervix. And you have something which is part of the cervix, of the vagina. That's called portio vaginalis. And typically, it is this end part you are having external os. And you should remember, between anatomical and histological, you are having the distance between the anatomical and histological. Anatomical is above, histological below. It is called isthmus. Isthmus is 0.5 centimeters. From the anatomical internal os to the point where this body of uterus is extending, this body cavity height is 3.5 centimeters. But body cavity height is not corpus. We talk corpus cervix ratio, no? But what is corpus? Corpus is from the top of the dome, even the top of the fundus. From there up to this anatomical internal os, you call it as corpus. Corpus is 5 centimeters. Body cavity is 3.5 centimeters. And between anatomical and histological internal os, you have the isthmus, which is 0.5 centimeters is what you need to remember. So, from the anatomical internal os to the external os, this entire extent is called as cervix. Now you got the clear idea, right? That is very important. You should get that very clearly. Is everybody clear about this? Good. So that is the advantage of sorry doc, I think the video is struck. Is the video struck? Please wait 1 minute, I refresh. Very good, doctor. Now, what is the definition of isthmus? Between anatomical internal os to histological internal os, it is called isthmus. Right? We are all clear. What is the importance of isthmus? From the second trimester of pregnancy, that means after 12 weeks, right? Isthmus forms the lower uterine segment. Lower uterine segment. We do lower segment cesarean section, no? Actually, we are cutting into the isthmus, which is between anatomical and histological internal os. So, how do you recognize the isthmus during cesarean? There is a loose fold of peritoneum. It's called uterovesical fold. That is the one which make you to recognize, oh, this is the isthmus. Now, when the term pregnancy happened, term pregnancy, and the lower uterine segment is formed, who contributes to the lower uterine segment in term pregnancy? Isthmus contributes 70%, cervix contributes 30%, is what you need to remember. Now, what is cervix? It is between the histological internal os to external os. It is cylindrical in shape. And what is the length of cervix, doc? The length and diameter, both of them are equal to 2.5 centimeters. And the cervix has a supravaginal portion which is called endocervix. It is about 1.25 centimeters. And the vaginal portion, portio vaginalis, which is called ectocervix. Both of them are equal to 1.25 centimeters. So, cervix is divided. That portion of it which is in the vagina, which is called ectocervix, and which is above the vagina, which is called endocervix. Each of them are 1.25 centimeters. Right? Now, if you look at the cervix, endocervix, that means supravaginal portion. What is the lining of it? It is the tall columnar epithelium. It has complex racemose glands. It secretes alkaline mucus, and the pH of it is alkaline, 7.8. Ectocervix, that is the one which is there inside the vagina. Non-keratinized stratified squamous epithelium is the type of epithelium of ectocervix, is what you should remember. Now, corpus cervix ratio, one of the favorite questions of the exam. Before puberty, at puberty, reproductive age group, after menopause, that's how you divide. Before puberty, it is 1:2. After puberty, 2:1. Reproductive age group, 3:1 to 4:1. And after menopause, both cervix and the corpus, they both atrophy. Now, doctor, this fellow internal os is there, no? There is a lot of surgical significance for internal os. I told you, no, one external os, internal os. Internal os has one anatomical, histological. Right? Now, anatomical internal os to histological internal os, the distance is called isthmus. At the level of internal os, the peritoneum is reflected onto the bladder. Right? So, that is very important. That will help you to identify the internal os during cesarean section. Uterovesical fold. Then, the uterine artery starts moving up. So, typically the uterine artery will start moving up at the level of internal os. And at the level of the internal os, the uterosacral ligaments. So, typically you are having the vertebral column and coccyx. So, here you are having the uterus and cervix. Right? So, the uterus posteriorly, what do you have? Uterosacral ligament, that is at the level of the internal os. And McEnroth's ligaments are below the level of the internal os. Below the level of the internal os, they come and does the attachment is what you should remember. So when the person is in an erect posture, internal os is at what level, external os is at what level? What are the anatomical landmarks? You know, symphysis pubis is there, no doctor, in the pelvis, right? So imagine you are having the ischiopubic ramus. So upper border of the symphysis pubis corresponds to the internal os. And the ischial spines, they correspond to the external os. So that is what you have to remember. Not ischial tuberosity, ischial spines. You remember the greater sciatic foramen, lesser sciatic foramen, the relation with the ischial spines. Those ischial spines I am talking. It is at that level you have the external os, whereas upper border of the symphysis pubis is the place where you have the internal os. What is the most common site for the carcinoma cervix and carcinoma in situ? It is this transformation zone is the most important site, squamocolumnar junction. Then the transverse vaginal septum. Few people develop a transverse vaginal septum. It is at the level of the external os. That's the reason you need to remember. Now, what is the neurovascular anatomy of uterus? Uterus has a sensory supply. Sensory supply. How does it come? For the uterus, T10 to L1. For the cervix, it is sacral. S2 to S4 is the sensory supply. Tomorrow, some of you are going to be finest obstetrical anesthetists. So, you should know all these funda. So, there is a uterus, there is a cervix. What is the lymphatic drainage? This is very important because carcinoma cervix, whole story depends upon this. Carcinoma cervix and uterine cancer. The fundus drains into para-aortic and lateral aortic lymph node, doctor. Para-aortic and lateral aortic lymph node. Body drains into external iliac lymph node. Cornu are there, no? Right? Where fallopian tube is rising. Superficial inguinal lymph node and even round ligament also drains into superficial inguinal lymph node. That is the cornual drainage. Then what are the lymphatics draining the cervix? Hypogastric, obturator, presacral, paracervical, external interiliac. They are all the ones which are the lymph nodes supplying the cervix is what you have to basically remember. Now there are three favorite questions of the examiner, doctor. Any exam, you take PLAB, MRCOG, any exam in the world, favorite question. What is the most common of all these lymph nodes which is involved in carcinoma cervix? Obturator lymph node. Obturator lymph node. Which is the first lymph node? First is different from most common. Right? Which is the first lymph node in carcinoma cervix? Paracervical group of lymph nodes. That is the ureteric lymph nodes. So that is the reason in the carcinoma cervix what happens? Once there is a parametrial invasion by the tumor, the ureter becomes stuck up. That leads to uremia and renal failure, the most common cause of death in carcinoma cervix. So paracervical group of lymph nodes get involved. They are the first lymph nodes to get involved. And which is the lymph node that is never involved in carcinoma cervix? Superficial inguinal group of lymph nodes are never involved. Superficial group of lymph nodes only supply are drained by cornu of the uterus. But cervix, carcinoma cervix does not involve superficial inguinal group of lymph nodes. Now, doctor, what is the blood supply of uterus? Uterus is supplied by uterine artery, ovarian artery. Very easy thing. Cervix, It is the descending cervical artery, which is the branch of the uterine artery, is what you have to remember. So, doctor, this is a little initiative that we have taken with the handwritten notes. So please don't forget, at the end of the video, after this video get published, below that you please write your feedback. Your feedback is very valuable to us. And once more, let me tell to all of you, I am going to be your classmate every day. I am going to be with you until you get the seat. And onlinembbs.com is the best video library. You have 3,000 video lectures, 2 lakh PowerPoint slides of notes, 30,000 MCQs, and we also have a WhatsApp study group where about 20,000 students, daily we have a lot of interaction. And you need not go anywhere to find a help for cracking the NEET PG or FMGE or final year exam or anything. We are always there with you. In addition, every day we keep on taking an opportunity to discuss live online to inspire you to study. And on every Sunday, morning 9 to 5 p.m., one subject, 45 Sundays, 2 cycles of revision is there. So tell your juniors, classmates, everyone to subscribe to onlinembbs.com video library. Once more, we will catch up tomorrow. Thank you and good night and thanks for coming. Thank you.